I'm Anna Luker. Together with Maya, we co-direct Peds Echo, and we will be manning the chat. So any questions, please feel free to add them at any time. And you can, of course, always unmute yourself and share your beautiful voices with us. And then without much further ado, Dr. Rodolfo Bégué, again, kindly stepping in to save the day and teach us all about congenital syphilis today. So I will hand it over to you, Dr. Bégué.
Thank you. How do I get my screen up again? Share screen again?
Share screen, yeah, the bottom green in the center. There you go.
Right. So now you can see it?
Yes.
Okay, thank you. Thank you very much. Thank you all for the invitation and all those who join in the call. I want to talk a little about syphilis in the baby because we get a lot of calls about that. It's usually sort of confusing. Most of you have an overall good idea of what to do, but there's usually some nuances that make things a little more tricky. And hopefully I can assist you in that in some way. I have no disclosures, and these are the objectives that were just presented to you. And this is my outline for today. And as you can see, we're going to start with some little trivia that you can use about syphilis. Syphilis has been around for so long that there's so much trivia around it. But couple of things that I want to emphasize. One is the name syphilis, which is such a beautiful name, and it was initially given by this doctor, Girolamo Fracastoro, Italian doctor, who in 1500 wrote this book, a 3-tome book called Syphilis Syrbe Mobius Gallicus, which I better won't translate because it's a little xenophobic. But in the book, there is a poem called The Maladies of Syphilis. Doctors, by the way, those days did not write in prose, they would write in poetry, and they would write in Latin. And in that poem, he says that he talks about a fictional character named Syphilis, who was a shepherd, and he describes the ailments of syphilis, which is the first comprehensive description of syphilis. And the name syphilis turned into syphilis with time. But that's how the name came about. And then the other piece of trivia comes from the first treatment for syphilis, which was the so-called Salvarsan. Was developed by Paul Ehrlich, the same eponym on ehrlichiosis. He also coined the term chemotherapy back 100 years ago, meaning therapy with using chemicals for medical indications. And then the concept of magic bullet, knowing that he could use certain dyes to stain bacteria specifically without touching human cells. He thought that he could attach a toxin to those dyes and then direct specifically to the bacteria and kill the bacteria without causing any damage to the host. And this was what he called the magic bullet. And believe it or not, he started working with arsenic, one of the most toxic substances that we know of. And he made modifications over and over again until he came up with the so-called Salvarsan, or 606. Also number 606 because it was the 606th trial that he had. So can you imagine how vested he was in his work, that he tried over and over again until he came up with something. And the discovery, development actually of Salvarsan 606 awarded him the Nobel Prize in 1908. And then as soon as the publication came out, only a month later, a report, which is the references shown at the bottom by Dr. Jones from Walter Reed, described 20 soldiers that were treated with Salvarsan for syphilis. And believe it or not, in the publication, if you ever get a hand to that publication, in the publication, they list the name of the 20 soldiers that were treated. We could not do those these days, but that's how medicine has progressed in the past 100 years. After that, penicillin came about and replaced Salvarsan, so everyone forgot about Salvarsan. And fortunately, penicillin still remains active against syphilis. So let's start talking, let's get to the point and start talking about the stages of syphilis. This relates to acquired syphilis, so it's more to the mom and how it relates to the baby. And we know there's basically 4 stages: primary, secondary syphilis, primary syphilis, secondary syphilis, then come a stage of a latency called latent syphilis, and then comes tertiary syphilis. Primary syphilis is the chancre, which is an ulcerated border elevated lesion, which is usually non-painful, even though sometimes if it breaks the base of the skin of the mucosa can produce some pain, and usually appears about 3 weeks after the exposure. Then it goes away even without treatment, and then about 1 or 2 months later comes the secondary syphilis, where the rash we all heard about, is the most characteristic one. And then comes the latent syphilis. Again, that also goes away even without treatment. And then comes early latent syphilis, which can be divided into early, if it's the first year, or late, which is more than a year. It's asymptomatic by definition. And the first 3 options, primary syphilis, secondary syphilis, and early latent, can be treated with a single dose of benzathine penicillin. The late latent syphilis, so the one that has been sitting there for more than a year, requires 3 doses of benzathine penicillin. The problem is that many times we don't know when someone acquires syphilis, and we don't know if it's early, and if they're asymptomatic, unless they present as primary or secondary. If there's asymptomatic, which is most of the cases, then we don't know if it's early or if it's late. The basic rule of thumb is that if you cannot determine if it's early or late, you should treat it as if it's late. And that's why many pregnant women, unless there's prior tests that show that they were negative within a year, they should be treated with 3 doses. And tertiary syphilis, which we rarely see nowadays, comes years, decades later, and affects all organs, and in particular CNS and cardiovascular. Those require IV penicillin. So most of our mothers that we deal with will come either with latent syphilis, and will come either with early or late. And in those cases where we don't know, then we should assume they may be late, and they may need 3 doses of benzathine penicillin. This is also important in terms of the risk of transmission to the baby. We know that those who have primary syphilis, so at the time of the baby's born, they tend to transmit more than if they're secondary syphilis, early latent, or late latent syphilis. So how the mom gets into pregnancy, a stage of syphilis, may determine the risk to the baby. That said, there is a risk for any of all those situations, so they all need to be detected, and they all need to be treated. And then the baby will present with a number of clinical symptoms, which in general are divided in what is called early congenital syphilis, which happens usually in the first 2 years of life, and then the late congenital syphilis, which happen after 2 years of life. Early manifestations, well, the most consequential are stillbirth, prematurity, or hydrophytalis. If untreated, about 40% of children will have major consequences during pregnancy. Those who pass that stage and they're born, most of them may be born asymptomatic. They don't have any obvious symptoms of syphilis, but some of them may have the classical symptoms of early syphilis, which are listed there. Snuffles is the nose with bad secretion. They can have mucocutaneous lesions. They can have a rash, similar to the secondary syphilis that we see in adults, lymphadenopathy, hepatosplenomegaly. They can have different organs involved, the lungs, the bones, and joints. When they have major inflammation along the bones, they may not move that extremity and come with what is called a pseudo-paralysis. And sometimes they have hematologic thrombocytopenia, hemolytic anemia manifestations, or kidney nephritis, nephrosis. We rarely see these cases these days because, again, testing and treatment tends to be more aggressive now than it was before. But you may see them occasionally in patients who have no prenatal care or who falls through the cracks. And those who don't get treated, then they can, even if born asymptomatic, then they can go on to develop the late manifestations of syphilis, which we rarely see these days. You may see them on patients who come from other areas and where they may have not had any treatment, or immigrants from deprived areas where again they didn't have much access to healthcare during their pregnancy. And those late manifestations affect mainly the CNS and the musculoskeletal systems. And there's a number of well-known eponyms in different manifestations of syphilis that affect the teeth, the eyes, and everything else. And I'll show you some pictures here, which are, to me, are actually more historical than anything. I've seen a few cases with early congenital syphilis. You can see here a neonate with hepatosplenomegaly, jaundice, and prematurity. You see a baby with snuffles here. You see the bad, horrible secretions around the nose. Those are very contagious. You want to wear gloves. You want to be very careful when you touch those lesions. On the right, you see the rash, in this case, all the way down to the soles, and here on the face, which again is reminiscent of secondary syphilis that we see in older persons. And then the musculoskeletal problems with periostitis, which is a radiological finding, and that's why we do the long bone x-rays, and sometimes leading to deformities and pain and a lack of use of that extremity, the so-called pseudoparalysis of Parot. Again, we rarely see those these days, but you may encounter some of them once in a while. The late manifestations are probably you will never get to see, but just so you are aware, saddle nose, which is destruction of the septum of the nose, the frontal boss, which is the protrusion of the frontal of the forehead, ragadis, which is lesions around the mouth, and then the so-called Hutchinson teeth, which are these sort of triangular indentations, mostly in the incisors. They can occasionally be seen on the molars too, but you need probably a dentist to actually, or oral surgeon to look at those and actually tell you if they think those are manifestations of syphilis. We saw one kid that was a long time ago that was adopted from a different country and with unclear birth history, and this baby happened to have teeth manifestations and CNS manifestation and a positive RPR that made us worry about late congenital syphilis. But other than that, it's very unusual to see. So even though you may not see too many symptomatic cases, you know, the regular textbook cases, you're going to get exposed to a lot of kids who are born exposed to syphilis, and that you need to make decisions about, right? And this slide tries to show the incidence of syphilis, how's it been going on in the U.S. On the left side, you have a graph from CDC from about 10 years ago, showing how syphilis was going down. The columns, you can see how syphilis was going down. From 2008, it was 10.5 for 100,000, went down to 8.4 for 2012, but then it started to go up to 11.6 to 2014. And then the most recent information in the past 5 years, from 2017 to 2021, shows how the numbers have been going up in the US and in Hawaii, to the point that Hawaii is now above the average in the USA, actually is number 10 in the states in terms of rates of congenital syphilis, and the numbers keep going up. So this seems to be a problem that is real and that is out of control. And well, it's multifactorial. We can discuss at some point what could be done, but at this moment, we just have to deal with that. And if you have an impression that you've been seeing more cases of syphilis lately, you're right, that is what is happening. Actually, I went back for this lecture to look at my files, and I found that I've been here for close to 2 years, the first case I saw in consultation was a baby with syphilis, and the last case that I saw last week was a baby with syphilis. So I've been seeing syphilis from beginning to end, and it looks like it's going to continue to happen. So syphilis is on the rise for the US and for Hawaii. So how do these moms, today we are particularly interested in congenital syphilis, so we'll have to review pregnancy syphilis and baby syphilis. So testing for syphilis during pregnancy, mom ideally should be tested 3 times early during pregnancy, which means the first time that she is encountered by the healthcare system, whatever it is. Sometimes there's a mistake of seeing these moms in ED or urgent care and then referring them to OB, and you don't know if they're going to go to OB. I mean, when they could be tested right there and know if they are positive, and then they could be started on treatment. So the first contact should be a reason to get them tested, and then they should be retested, hopefully at the start of the 3rd trimester, 28 weeks, and then at the time of delivery. Now, rarely do we see anyone to have this 3 tests. If we're lucky, we have 2, 1 during pregnancy and 1 at the time of delivery. Many times we have only 1 at the time of delivery, and we still have to make decisions. So it's a failure to some degree of the system that we still cannot get to these moms in time and get them on treatment in time to prevent the problem to the baby. In terms of the baby, if mom is negative for syphilis, then okay, the baby does not need to be tested. But if the mom is positive, then the baby must be tested. And no baby should be let go home until there's some conclusion about that mom has syphilis or not, and that the baby needs to be treated or not. Sending them home for a phone follow-up is not appropriate. And what do we use for testing them? Okay, well, this is probably well known to you, but let's clarify a couple of points here. We have a combination of non-treponemal and treponemal tests, right? The non-treponemal tests are usually, there's 2 ways. The traditional way, which is what is mostly used in Hawaii, which is the non-treponemal followed by the treponemal. Some centers may use what is called the reverse testing approach, which is doing the treponemal first and then followed by the non-treponemal. There's some pros and cons about that, but if it's not, because it's not used too often, probably I won't spend too much time talking about that. So let's talk about the non-treponemal first, which is most of the time is RPR, what is being done. Occasionally BDRL, we'll mention about that later, but it's mostly RPR. The non-treponemals are more sensitive, so they're used for screening, but they're not quite as specific. That's why they need the follow-up for confirmation. The good thing about the non-treponemal is that they give you a titer, which means activity of the disease. So if the RPR is high, not only you are positive for syphilis, but it's very high, very active. If it's low, you are positive, but it's not so active either because you've been treated or because it's been long time since you've been infected. That is because the non-treponemal, the RPR, is not too specific, and it has to be followed by a more specific test, which in this case is a treponemal test, and the one that is being used here is the TPPA. It's more specific, which means it's used for confirmation. The problem is that once positive, it's always positive, and it can take decades to be positive. So there's no, once someone is TPPA positive, there's really not much benefit in keep testing as long as we know that for TPPA, as long as we know they are positive. If RPR is positive, but TPPA is negative, that means that the RPR was a false positive. Remember that TPPA is the confirmatory, the RPR is the screening. And what about the baby? Well, the baby, we basically do non-treponemal, the RPR. And that is very important because we compare that to moms to have an idea of, is the baby infected? What is the chance that the baby is actually infected with syphilis? And it also helps us with response to treatment. That's the one that we use for follow-up to see if the treatment was appropriate on the baby. The treponemal we really don't need because, again, whatever mom has will be on baby's blood. The treponemal doesn't mean anything different. It's only passive maternal antibodies. Some people have the wrong idea that if the baby is RPR positive, and TPPA positive means the baby is infected, but if the baby is TPPA negative, then the baby is not infected. We don't interpret that way. Okay, if mom is positive and the baby is RPR positive, that is enough risk, and we'll talk about what approaches we can take in those cases later. But don't put too much emphasis on the TPPA on babies, because that's mainly maternal antibody reflection.
Dr. Bégué,
So,
can we ask a quick question that popped up?
yes.
Dr. Ware wants to know, is it routine part of the prenatal screening for every mother to be tested at delivery, or is that like clinician judgment and your recommendation?
No, it should be a routine.
Thank you.
So how we interpret these combinations for the mom, and again, I may be repetitive, but I want to make sure people get it clear. If the RPR is negative on the mom, then that's it. No test for TPPA, there's no syphilis, there's no problem, no treatment for mom, no treatment for the baby, right? That said, rarely you can have false negative RPR, like if it's very early primary syphilis, mom just got infected a week ago, a week before having the baby, and she may not show a positive RPR, or when it's very late, and it's been years since mom was infected, with many years without treatment, the RPR may go away and still mom may be a problem. And then there's the so-called prozone phenomenon, which means that you have so much antibodies that your test is negative and you have to dilute the blood test to make it show it. That's very rare, and it's not routinely done. So unless you have a good reason to think that your RPR negative in the mom may be a false negative, then you really don't want to push to have any of those tests. But just be mindful that in general, negative RPRs mean no syphilis in the mom, but occasionally you may have some false negative. If there is any doubt, like let's say mom again got infected soon after having, before having the baby, then you want to repeat that in 2 to 4 weeks to make sure if now she converted, or you can call ID and then we can have a conversation about what to do about that case. If the RPR on mom, on the other hand, is positive and the TPPA is positive, that man have syphilis, and then mom should be treated, right? You want to be aware of this rare thing called serofasting, which is that mom had syphilis, she got properly treated, and her RPR fell, not completely disappeared. Let's say went from 1 to 64 down to 1 to 2. And she's properly treated and just stayed on 1 to 2 for a long time. And now this pregnancy, she remains at 1 to 2, and you don't know what to do because she's 1 to 2, she's not negative, and her TPPA is positive because she had syphilis in the past, but she has a very low level. That's a possibility of the so-called serofasting. In that case, theoretically, that mom is okay because she has been treated, but sometimes it's hard to discern if this is serofasting, so a low level that will remain for a long time, or if this is a new infection that it hasn't gone away and you should be treating the baby. And that's a little tricky. And again, you can call ID to discuss that. And finally, RPR positive and TPPA negative, meaning that the RPR was falsely positive because the TPPA, the confirmatory test, is now negative. Then mom has no syphilis, so she doesn't need any treatment, and it should be called a false positive, and the baby doesn't need any treatment. And false positives, RPRs, can happen for reasons that we don't understand or completely understand. Pregnancy by itself can give you low-level RPRs, 1 to 1, 1 to 2, maybe no more than 1 to 4. Autoimmune diseases, if mom has lupus or something else, she could test positive for RPR. Or if she has infections that stimulate your immune system, right? Like EBV infection, or if she has chronic infection, like chronic hepatitis B or chronic hepatitis C, those can give you low-level false positives RPR. Again, if in doubt, repeat it in 2 to 4 weeks. Again, the RPR, the TPPA, if it's still the same number and the same result and the numbers haven't changed, the RPR hasn't gone up, then probably this is a false positive and you don't need to worry about this scenario. If there's any question, about mom being positive, if you think you confirm that it's positive or you have any questions, the first thing is to start appropriate treatment of mom, right? And because that, a lot of what we do with the baby depends on mom being treated. We need to remember that appropriate treatment in mom has to meet basically, have to check every perfect box, right? It has to be with penicillin. There's no alternative. If mom is allergic to penicillin, she needs to be desensitized and given penicillin. Any mom who's treated with anything but penicillin is not considered appropriate treatment for the baby when it comes to making decisions on the baby. It has to be given 1 or 3 doses depending on the stage of illness. And again, if it's not known, if it's early or late, go on the safe side and give the 3 doses. Has to be given IM once weekly, right? Meaning 7 days between doses. There's a very little window of grace period that you can allow, right? If it's the mom shows up 1 day early, let's say it's weekends, whatever, sometimes they scheduling the next dose is not as easy as it sounds. You can do it 1 day later or maybe 2 days later, but that's the most that you accept. If mom takes more than 9 days to come back for the second dose, she have to restart the whole series of 3 again. So it's a very narrow window. You can try to have a very little wiggle room there, but anything but that, they have to restart the series again. And it has to be completed. So if it's 3 doses, the last dose has to be given at least 4 weeks before the baby is born. And many times we don't see that happening. And then ideally, you want to have enough time to see evidence of serologic response on the mom, meaning a 4-fold decrease in the titer, right? Remember, RPRs are done in 2-fold dilutions. So 2-fold difference is basically from 1 well to the next well. So it could be basically it's the same result. 4-fold, so jumping 2 wells, that's a real difference. That's why most of the rules talk about at least 4-fold changes to decide that actually something has happened for good or for bad, right? So in this case, you want to have all these 4 criteria. If any of them is missing, then in principle, the maternal treatment is not appropriate and you may have to be more aggressive when dealing with that baby. So what about the baby? Well, when making decisions about the baby, this is the things that you need to keep in mind. First is you need to be clear if mom has syphilis or not. And again, remember, false positive, false negative, and those kind of things. Get as much information about testing on the mom so you can decide if you want to believe that mom does have syphilis or not. Then history of previous tests. So if mom has a 1 to 8, does this mean she's coming down from a 1 to 128? So actually she is responding well to treatment, or she's actually going up from a 1 to 4, and actually the treatment is not working, or she never got any treatment. So getting as many tests before from the mom may help you clarify what is the situation with the mom. The history of maternal treatment, if it was given or not, and if it was appropriate or not. Then the baby's RPR is very important, so you can compare to mom and see if it's the same level, lower or higher than mom's. And then the baby's physical findings, normal versus abnormal. So this is the very least, the 5 pieces of information that you need before making any decisions on the baby. And you have to decide how much you need to evaluate the baby, labs and x-rays and whatever, and how much you need to treat that baby. That's when you grab your red book and go over this infamous algorithm, which any algorithm that has more than 5 boxes is almost unreadable, right? And this has just too many. Most of you, when you call us, you have gone through the red book, you have gone through this, and you're just not sure exactly if you're following it right or not. And again, I understand because it's sort of confusing. At the end, at the bottom, if you can read it, it's a small print, but if you can read it, what the red book, this algorithm is trying to do is to classify the baby in the risk of congenital. What is the risk that the baby has congenital syphilis, right? Is it possible? Is it likely? Is it unlikely? Is it proven or what, right? And that's what this table takes you down to. So to make it a little easier, put this together, right? The left column, you have what the red book classifications are, from less risky to more risky, unlikely, less likely, possible, highly probable, or proven, right? I don't like those denominations because those are very subjective, right? I mean, what is less likely? I don't know. I mean, it means that it's less likely than what? I mean, so I don't like those text denominations. I very like categories. So on the next column, you have my interpretation, ranking them from 0, 1, 2, 3, and 4. So levels of risk, right? It's basically the same thing, but I'm trying to be a little more objective as opposed to subjective as the red book, right? It's up to you to choose either to follow me or to follow the red book, but of course, you know who is normally right. And given that, well, the first category, the 0 category, is not considered by red book. I mean by that, those who have no risk of syphilis, right? And I'll get to that in a moment. And then depending on that, you decide on how much evaluation you need to do to the patients. If there's no evaluation, or if there's a basic evaluation, or if there has to be a very comprehensive evaluation, and then decide on what kind of treatment you need to give to the baby, right? Either no treatment, or just give a shot of benzathine penicillin, or give them the 10 days of penicillin. And basically, regardless of what you decide to do, that baby will need to be followed closely to make sure that they do clinically well, respond well to the treatment clinically, and serologically, that the RPR indeed falls below, right? And this can actually even be simplified further in no risk, low risk, and high risk, right? As you can see, the low risk required basically nothing. The low risk required the most, a shot of benzathine penicillin, and the high risk are the ones who require the 10 days of penicillin. So I think it would do a favor to everyone if the red book were to simplify that algorithm. Instead of going to 4, 5, 6 different categories, it's just trying to simplify into minor categories, depending on how much workup. I mean, if it's a possible or a highly probable, as long as you're going to have to do the same workup and the same treatment, I don't know why you need to get into that minor discussion. And because the algorithm, again, is sort of hard to follow, I'm going to flip it over and present it more as clinical cases or scenarios, right? And how you would do with that, right? So the first scenario, which is the risk 0 that I mentioned before, so no risk, which is not included in the red book, includes a mom who is RPR negative, so no risk, or a mom who is RPR positive, but the TPPA is negative, so it's a false positive, so there's no risk, you don't need to do nothing. Or a mom, I include also, and that's why I call it 0B, a category in which the mom is RPR positive and TPPA positive, so she had syphilis, but she was properly treated, and then at the time of delivery, the RPR is non-reactive, right? That is very unusual scenario. I haven't seen one that has completely gone away, but if that was the case, you could make a case that, well, that baby does not need, as long as clinically fine, does not need any treatment. If you want to be on the safe side, you may want to give a dose of benzathine penicillin, but probably you don't need to do anything. You don't need to test that baby, and you don't need to treat that baby. Next level of risk, which is here risk 1A, is the mom has syphilis, so the RPR positive, the TPPA positive. She gets treatment, and at the time of delivery, the RPR is positive, so not negative as the one that I just mentioned, but it's still positive, but at a low level, right? Which is what we many times see, right? And I would say tentatively low, less than 1 to 4, and the baby's RPR is negative, non-reactive, right? And clinical evaluation is the baby's normal, then this is what the red book calls unlikely syphilis, right? In this case, I agree, probably you don't need to do any evaluations, you don't need to do any treatment. The baby is fine and the baby is non-reactive. I break this scenario into two, risk 1 and risk 1B, because in this second one, mom has syphilis, RPR positive, TPPA positive. She's properly treated, 1 or 3 doses, depending on her stage. And the RPR is positive at the time of delivery. Again, probably in the low side, but the RPR in the baby is positive, right? Again, the previous one, the RPR in the baby was negative. Here, let's say mom is 1 to 4 and the baby is 1 to 2 or 1 to 1, right? So it's lower or even equal to mom's. I gotta make a distinction here that the Red Book accepts as much as twice as high in the baby as moms in this scenario. Again, mainly because one well difference, it's okay. I get nervous if it's higher. If it's up to the same level, I would be okay, or lower. But if it's higher than moms, I would move to the next level, risk level. But anyway, just so you know, there's a difference here between the Red Book and my interpretation. So let's say again, mom was properly treated, her RPR is low, and the RPR in the baby is same or lower, but still present. And the clinical evaluation is baby is normal. Again, for the Red Book, this would be called unlikely. By the Red Book, you would need no further evaluation and no treatment of the baby. I would suggest that because the baby's RPR is positive, even so lower, and even so lower than moms, even so low and lower than moms, then I would feel better. It would make me feel better. Dose of benzathine penicillin to that baby because they leave the room. So I think this is a minor difference with what the Red Book says in my mind. The next level of risk is mom has syphilis, RPR positive, TPPA positive. She's properly treated. Her RPR is positive at the time of delivery, but now it's higher. It's more like 1 to 8. Let's say she started with 1 to 28, 1 to 64. Now it's down to 1 to 8 or 1 to 16. So it's not just 1 to 4 or 1 to 2. And the baby RPR is lower or even equals to moms, but again, is a significant RPR, and clinical evaluation of the baby is normal, right? Then the Red Book calls this less likely. I call it risk 2, right? And they say there's no need for further evaluation. I agree with that. But all these babies, because the RPR on the mom is significantly higher, it's less than 4-fold than where she started, but it's still significant high. I think I would give, or for sure, I would give benzathine penicillin to this baby. Now comes the higher risk. So those were actually low risk categories. Now comes the high risk, the ones where now things are starting to get really bad, right? And this is the risk 3 or possible risk as per the Red Book. Mom has syphilis, RPR positive, TPPA negative. She was not properly treated, so something went amiss. She didn't get penicillin. She didn't get it the 3 doses. She didn't get it in time. She didn't complete it before the 4 weeks, or she didn't have a drop in her serology. So even though she got some treatment, it was not properly treated. Then, and the RPR is positive at the time of delivery, and the baby RPR is positive, but lower or equal to mom's, and the clinical evaluation is normal. Then the Red Book calls this possible syphilis in the baby. This baby needs full evaluation, and I will mention what that is, and needs full treatment, and we'll mention what that is. And then the last risk category is mom with syphilis, regardless of if she was treated or not. And this is something you need to remember, regardless of treatment. Let's say mom, for the sake of discussion, did get treatment and things were looking okay. But if the baby is born with abnormal clinical findings, rash, mucocutaneous, some manifestations, or long bones x-rays abnormal, periostitis, whatever, then, or the RPR in the baby is greater than 4-fold of the mom's, the RPR now is not the same or lower, is higher in the baby than the mom's, or the baby has a positive test for syphilis, positive dark field or PCR, which are rarely done, but sometimes can be done on placenta or some specific lesions on the baby, then this baby is highly probable or even proven to have syphilis, needs full evaluation, and needs full treatment. So I hope this grading up different risk scenarios helps you to categorize better your patient. But at the end of the day, you want to know if it's no risk, low risk, or high risk, and how much you need to do. And for high risk, you need to do full evaluation and full treatment. And this is what it means. Full evaluation means a CBC to see if there's any hematologic problem. You do your CSF, and for BDRL, and you do your long bone x-rays. And depending on symptoms, you may need to check the liver, check the eyes, check hearing, chest x-ray, and neuroimaging. And for full treatment, you have to do penicillin G, 50,000 units per kilo. You start Q12 hours in the first 7 days of life. Baby who is more than 7 days can go to Q8 hours. and complete the 10 days of treatment for penicillin. If 1 day of treatment of penicillin is missed, then you have to repeat the whole thing. So 1 dose, 2 doses, you can go on, move on, and continue the treatment. But if it's more than 1 day full of worth of treatment for penicillin, then you need to restart the 10 days of treatment again. The alternative to IV penicillin is procaine penicillin, IM. I have never seen anyone do it here. People rather put a PICC line and complete the 10 days than do the IM. I'm not sure why. I think you can always put a PIB and get away with 4 or 5 days, or maybe even more. And if you lose the PIB, I would feel bad have put in a PICC line for 2 or 3 days. Those days I would try to get procaine penicillin G. It's not easily available. You may have to call your pharmacy and have them to stock it in case you need it, but it's an alternative. This is the only reason why procaine penicillin G was developed. So I encourage people to start looking into that. I haven't seen anyone use it. I keep recommending it every time, and no one takes my recommendation on that one. Infection control issues. Remember this kid's standard precautions. Wear gloves, especially when handling secretions or open lesions, especially for the first 24 hours of treatment. After 24 hours of penicillin, the contagiousness basically disappears. And breastfeeding is allowed the mom, unless mom has a breast chunker. So primary syphilis, a chunker, an open lesion in the breast. Of course, if it's one breast affected and not the other one, she can still nurse from the other breast. But that's the only contraindication. Other than that, breastfeeding is allowed. For follow-up, repeat the RPR every 3 months until it becomes non-reactive. So during your regular 2, 4, 6 months, you just examine the baby and do a repeat RPR. Many times these patients are referred to ID to get all this done. We are more than happy to do that, but we don't have to. Probably you can do that, especially in babies who have relatively low risk of syphilis. You can follow your RPR. You should expect a 4-fold drop in the titer by 3 months, and you should expect the RPR to be non-reactive by 6 months. Those RPRs that last more than 6 to 12 months in the baby, well, that's when you start to worry if the treatment was effective or not, right? If it's not dropping at all, or if it's increasing, obviously there is something wrong. The baby needs to be rechecked, including CSF, and possibly retreated. Probably at that moment you want to be calling ID. If the titer is dropping, let's say started with 1 to 16 and is now down to 1 to 1, and the baby is 6 months, well, probably it's not quite there yet, but it's getting there. So you can give it a little time, and sure enough, it should become non-reactive at some point. Babies who have positive BDRL in the CSF at birth do not need repeat LP routinely. This is a change in the Red Book, by the way. It used to be that they told you to do it. Now they say you don't need to do it unless the RPR is not dropping, right, by 6 to 12 months of age. In that case, then you reassess the baby completely, including the CSF. And if the CSF is still abnormal, meaning it's still the BDRL is positive there, or the cell count is high, then should consider retreatment. And again, that's another situation where you may want to be calling ID. Babies that were RPR non-reactive at birth, but were born to an RPR positive mom, so they look like a low-risk case, they should be retested at 2 to 3 months of age to make sure it's not that mom was just getting infected and the RPR was just showing and the baby was still not showing the RPR yet. You want to repeat that 2 to 3 months later to make sure now the baby is not RPR positive. If the baby was RPR negative at birth and then at 2 months it remains non-reactive, then that's it. Yeah, nothing happened to the baby, nothing to worry about. But you have to repeat that RPR. And remember, passively transferred maternal TPPA can remain positive for up to 18 months. So that's not unexpected. But if the TPPA remains positive more than 18 months, that means that the baby was infected. So a baby who was high risk, you treated the baby, the TPPA is going to be positive, and it can remain positive for a long time. The RPR hopefully will disappear. The TPPA may remain positive. If the baby is now 2 years of age and the TPPA is still positive, means that the baby got infected. Fortunately, you treated the baby, so everything is fine, but that baby is going to probably be TPPA for the rest of his life. I had a bunch of clinical cases, but I think I'm going to have to skip them, which I tried to illustrate, what I just said, but I'm going to skip them to try to give us some time for clinical questions. One thing, I don't know if this is important to you or not, how to call these babies. When they're proven, when they fall into the high risk category, proven, highly probable, or possible, I code them as congenital syphilis, because that's what I think they likely had, and it also gives me a justification for the follow-up and all the tests and everything else that we need to do on that baby, right? When in the ones that are very low risk, the situation doesn't look too bad, but just in case we're gonna do benzathine penicillin on that baby, then I normally call it exposure to communicable disease. I just don't want a baby have be labeled congenital syphilis when maybe the baby never had it. It was exposed, but it never caught congenital syphilis. So I don't know if this is important to you, but that's how I do it to try to make sure I don't mislabel these babies. And then I'm gonna, maybe I will have time for a couple of clinical scenarios. This is the summary, which is sort of long, but again, hopefully will allow you to pass your post-test. Syphilis and congenital syphilis is increasing in the US and in Hawaii, and we need to be alert and we need to do something about that. All pregnant persons should be tested for syphilis at the time of their first encounter with healthcare system, whatever that is, at 28 weeks, ideally, and at delivery. And syphilis testing in the mom requires a treponema test followed by a non-treponema test, and you need to have both of them to make your decision about the condition in the mom, if she's really has syphilis or not. Pregnant persons who have syphilis should be treated as soon as they're diagnosed, and they start with benzathine penicillin. And again, if you have a prior RPR that was negative 6 months before, then you can say, well, this is early syphilis, so 1 dose will do. If you don't have any records, or the only records are from 2 years ago when she had her prior pregnancy, then you may have to go for 3 doses, because you cannot say it's early, then you have to assume it may be late, and you go with the 3 doses. Appropriate maternal treatment is with penicillin. There's no alternative. Anything but penicillin. If you want to treat the mom and the baby, you have to desensitize that mom and give penicillin. It should be completed at least 4 weeks before the baby is born, and hopefully you should have enough time to see a 4-fold drop in the titer. The risk of congenital syphilis in the baby depends on the mom. If she was properly treated, the titer of the mom versus the baby's clinical findings, and the lab results. When in doubt, opt to treat the baby with either 1 dose of benzathine penicillin if low risk, or 10 days of IV penicillin or IM procaine penicillin if the baby is of high risk. And then follow post-treatment, always the RPR, every 2 months to document a decrease in an eventual non-react. And don't feel short to ask questions. There is a nice department at the Hawaii Department of Health for STI and HIV, and the number is set there. I spoke to them yesterday, and they're very nice, and they're very helpful, very knowledgeable, so they can assist you in making decisions on your patient. Or if you want, you can call us, and the numbers are listed there, and we also will be happy to assist you in figuring out what to do for your patient. And I'll stop there, and I'm in a few minutes for questions or comments if there is any from you guys. And again, I appreciate the opportunity.
Thank you so much, Dr. Bégué. I will we'll leave the poll open for a minute so everyone can go through the questions. And then in the meantime, one question has come up already, whether the baby dose of penicillin is based on weight, which I believe so, but I should not be the one answering this question.
So the dose is weight related, right? It's 50,000 units per kilo, right? But it's not like, depending on the weight, you decide what product to use or how long to treat or any other consideration, right? If I'm understanding the question correctly.
Yeah, I think it was just to confirm confirm dosing. Excuse me. Let me drink a sip of water. I don't see any other questions coming through just yet, but I'm sure everyone is busy answering your questions. So I will.
Yeah, hopefully they all will excel on their test.
Hope so too.
We're about a third of the way done, so we'll leave it open a little longer. Any other questions for Dr. Bégué? No, Dr. Luker and Dr. Maxim are doing the questions too.
Yes, absolutely. Thank you. I went very silent for a minute as well while I was reading through the questions.
Anyone can feel free to unmute yourself or post your questions in the chat.
Dr. Bégué, how much community awareness is there of the rising rates of maternal and congenital syphilis? Is this something that there's any kind of like educational outreach being done by DOH or anyone else, or any other type of like community engagement?
Yeah, I don't think there is enough awareness out there, and I understand that DOH is trying to increase awareness and work in vulnerable populations, which are relatively well established, even though this is a relatively universal problem. I think Dr. Katz was on the call, and I don't know if he can better explain what their outreach may be.
Yeah, thank you very much. Beautiful job, Dr. Bégué. Absolutely wonderful. So yes, we had a learning community that was coordinated by the California Prevention Training Center last year, and we had sent out notices to all providers, and we had a very good uptake with that. We're also working right now on the Big Island, where we have a huge increase in congenital syphilis cases with Healthy Mothers, Healthy Babies. We're working with H3RC here to do outreach, because the problem is, as Dr. Bégué said, women who are just getting their test at delivery. So we need to identify people a lot earlier. We need to screen young women of reproductive age, and we're actively working to try to get that done. And we're sending out a notice right now. Dr. Felton, who's our communicable disease chief, is formulating a notice to go out. So thank you again very much. A great job.
Okay, we'll end the poll. Dr. Bégué, if you could just go over number 2 and 4. I think those are the ones with various answers. They're kind of split down the middle on the answers. Can you see the questions still?
So number 2 is all pregnant persons should be tested for syphilis at the time of first contact with healthcare system and at time of delivery. And it asks what testing for syphilis include. Well, yeah, so I guess everyone is right in that, yeah, it does include non-treponemal, includes treponemal, but the best answer, I guess, is both of them. Yeah, so the intention of the question was to make them aware that there's two types of tests, and that most of the times you need the two tests to make your decisions. If your RPR is negative, then you don't need a TPPA, but most of the time, if the RPR is positive, you do need your TPPA. So I don't know. I mean, maybe you should have read the best options as opposed to, because I mean, answering non-treponemal is not bad. Answering treponemal is not necessarily bad, even so it's not complete. So I'll give them half a point, I guess. And 4 is for proven, highly probable, or possible congenital syphilis. So these are the higher risk situations. Appropriate antimicrobial treatment would include, again, yeah, well, aqueous crystalline penicillin G and procaine penicillin. So either, yeah, both the IV form or the IM form would be could be used. Benzathine penicillin should not. So similar to the one before, yeah, I mean 1 and 2, which includes 1 and 2, should be okay. The ones who answer benzathine penicillin, that would be wrong. All the others are either completely right or half right.
Great, thank you.
I will always take half points as well. Thank you so much, Dr. Bégué. I actually do not see any questions otherwise in the chat unless I missed something. I am seeing some thank yous and beautiful job. Very much agree. Thank you so much again. I think this is definitely a topic that I hope will be, spoken about more and more, just to raise more awareness as we are seeing more cases. And it's definitely something that we've been seeing more in the hospital as well. So thank you very much again. Thank you so much for jumping in and saving all of our CME this week.
Thank you.
And we will see everyone back for our first session in June. Summer, can you help me out?
Yeah, it's Dr. David Kurahara.
Yes,
Yes,
excellent.
yes.
Correct.
Evaluating joint pain with no swelling and positive.
Everyone's favorite thing, to get an AMA and an ANA and then not know what to do with it. So I'm very much looking forward to that session as well. We will see you all then. Thank you so much again to everyone, and have a great rest of your day.
Thank you, everyone. Have a great
Thank you.